topics today. The first is using substrate and entrainment mapping. Now, Professor Belhassan, you can tune me out here when I talk about electroanatomic mapping, but there will be some physiology in here as well. Now, we all have this problem, and increasingly so, that we have a lot of patients with recurrent VT and post-infarct patients. This is because of a couple of things. Our secondary prevention patients are living longer because of heart failure therapies, and our primary prevention patients are actually having some arrhythmias, not all just permanent primary prevention. And we all know that, as you're finding in your registry, and I applaud that initiative, that ICD therapy is far from optimal. We have inappropriate shocks. Shocking is bad. Everybody knows that nowadays. We used to think that was a great thing, but now it's very clear that increased mortality and certainly decreased quality of life. But on the other hand, catheter ablation in these patients can be very challenging for a lot of us, even those who are very experienced with this. Patients are ill. They have a lot of comorbidities. VT is poorly tolerated or not inducible or non-sustained. And so we've had to make some modifications of our techniques over the years, and that is where scar mapping and ablation comes in. Now, part of this is I train my trainees in being as prepared as possible. You have the Boy Scouts over here. I was a Boy Scout. Be prepared, right? Be as prepared as you can before these procedures get going. So we know that most people with post-infarct VT without structural heart disease have a focal origin of tachycardia, with rare exceptions. And on the other hand, most people with structural heart disease have scar-based VT with reentry as the substrate. Now, it's important to be able to distinguish between these two, especially in cases of incessant VT, because they may be either focal or reentry, and whether that's scar-based or not. And sometimes the arrhythmia just doesn't fit any patterns with which we're familiar, and that can be a significant problem. Oh, about 20 years ago now, a little longer than that, Jacques de Bakker in Holland had some very innovative work on the pathology of these patients. And this is a specimen that we had from the operating room. Actually, this is a pre-transplant patient. This is his old heart. And you see the scar on the endocardial surface, and then some muscle, and then some more scar, and just a smattering of things. And this is a cut section not of this, but of a papillary muscle from de Bakker's work. And the scar is in black, and the surviving muscle bundles in stippled. And you see these multi-component fragmented unipolar electrograms. And this is our problem, how to deal with this, how to find the right area to ablate. We know that people with macro reentry have very slow, staggering conduction, either in a very long path or on just a very circuitous conduction path. And nonetheless, the fact that there is a discrete QRS complex means there's a constant, consistent exit from beat to beat. Otherwise, it would look different each time. Now, what we're trying to find is that vulnerable portion that we can ablate and leave the rest of the ventricle relatively untouched. And in post-infarct VT, that is typically subendocardial, in or near the border of the scar. In cardiomyopathy, it's still mainly endocardial. There's a lot of hubbub about it being epicardial, but it's still mainly endocardial, with a greater proportion than in post-infarct being subepicardial. But still around the scar areas, especially in the perivalvular regions. And in the postcongenitals, they can be around the scar ventriculotomy. Now, I can't help but go back to my roots at the University of Pennsylvania in intraoperative mapping. This is one of the last cases I did. This is probably almost 20 years ago now. We've supplanted this so much with catheter ablation. But this is an intraoperative map of a guy in whom we used to play around with this. I'd ask the surgeon to move the probe around and then say, okay, this looks like a good spot. Press here, and you see the tachycardia terminates. And this is such a small electrogram, you have to have arrows to help you out. Here's a larger electrogram here. And in this case, the impulse gets past the diastolic electrogram, then fails. In this case, it fails before the diastolic electrogram. And we used to do this all the time in the operating room. We also had multipolar electrode arrays. Here's a one on a septum. This is a 4 by 5 bipolar array, so 20 bipolar pairs in about just a few centimeters squared. And you see a couple of things here. One is this is a diastolic propagation here, and then there's another wave that goes along here. We didn't understand this very well at the time. And what is a different example here where we have during this run of electrograms here, this consistent coupling where there's a diastolic component and a systolic component, and almost always the diastolic component was sharp and very superficial, and the systolic component is very muted. And we decided to investigate this a little bit further with some studies using this multipolar electrode array. Here's an anterior apical infarction, and we'd map during VT, map during sinus rhythm right before a resection, do the endocardial resection with the heart warm and beating, presumably eliminating some of the circuit, and then record over that area afterwards. And then we put the specimen back in place just to see what effect that would have at the behest of one of my fellows at the time. This is what we found. Here is pre-resection, and you see these, the end of the QRS complex, and just an operational definite. The end of the QRS with these late potentials and certainly split potentials here. And then after resection, you see a couple of things. Those guys are gone, and the systolic component is much larger than it was during sinus rhythm before. Well, did the electrode array move? Are we recording a different site? No. We put the specimen back in place and record through it. And so these electrograms are the same as these. It's just, in essence, filtered by the scar, muted. So these become far field, and that's what we see during systole in these cases. And of course, the late potentials are still gone. All right, now when we're dealing with these cases, there are many different ways of approaching them. One way to do it is determine your VT mechanism. I think this is always worth doing because you can spend a lot of time looking for a mid-diastolic potential that's not there because it's a focal origin. So if it is a focal origin, induce and map and so forth, and then assess your results afterwards. If it is scar-based macro reentry, a couple of approaches to that are to delineate the areas that might be of interest, and do some map and VT and ablate, and then consolidate with some scar area ablation, and finally assess results. Another way of putting this together is at the beginning of the procedure to see where your scar is, the variety of methods, pre-procedure and afterwards, ablate around the scar using different strategies that we'll talk about, and you're done. Well, that's easy. You don't need a lot of skill to do that in most ways. But another way to do it is to attempt to induce VT. If it's mappable, go ahead and map and ablate, and then attempt reinitiation iteratively until you're done. If it's not mappable or non-inducible, then go to the ablation of scar, and when you're finally non-inducible, then you're done. So it's a little bit more circuitous. We're dealing with circuits. Now, I give my trainees this kind of algorithm here. This is not a typographical error here. This is, before you get started, it's step -1, preparation goals. Know what you're trying to accomplish. Because these people are very sick. They have residual ischemia, pulmonary disease. Some have a left ventricular thrombus. You don't want to be surprised by that. And medications may have to be adjusted. And these factors here will modulate what can be accomplished during the procedure. And then you have to decide, what am I really trying to accomplish? Our goal of therapy in most of these cases is to prevent recurrent shocks, make life better, not to cure the patient necessarily. So these factors limit what you want to accomplish during the procedure. And there's always a tension between how much can we do and how much is safe to do. This is another patient who's had a heart transplant. This is the old heart, and this is a big glob of thrombus in the apex. You see the scar around it, and beneath that is scar as well, but this is an organized thrombus. Now this is important from a couple of perspectives. Obviously, you don't want to be waving a catheter around when there's fresh thrombus. This is probably not much of an embolic risk, but the VT is going to be beneath that. You can't get there unless you have a catheter with a drill on it or something. You just can't reach that spot. And we've had several cases on which we had to do surgery because we couldn't reach the spot. Here's a calcified aneurysm here. You can't see it as well without the aid of arrows, or a cine. And I was very concerned about this case because I thought there was going to be a lot of thrombus all in here. Organized thrombus, not an embolic risk, but just in the way, so we couldn't get to the spot we needed to. It turned out not to be a problem. Now, how do you know what to ablate? Forget this for a second here. We need to look at the sites that have these surviving bundles of muscle. We know that in normal tissue, there's a sheet of muscle with very uniform propagation of a lot of cells firing at once, or nearly simultaneously, leading to a normal electrogram, this large wavefront. Whereas much of this is replaced with scar tissue. Cells that are still connected take a circuitous and slow, rambling course, leading to this fractionated electrogram, with which we're all familiar. And these can be seen in sinus rhythm. Here's nearly continuous diastolic propagation here. This is an unusual case. But notice how just a few millimeters away, you don't see anything of that. Nothing of this prolonged diastolic propagation. That's clearly repetitive. It's clearly not an artifact. And here it is in sinus rhythm with this very strung out, typical in inferior infarctions. All right, how do we determine where scar is prior to getting into the lab? Because we want to spend as little time in the lab as possible, make as best use of the time as possible for the patient. Well, infarct location is going to be an obvious source. Now, with so many people having biventricular devices, you can't tell that so well from the ECG, but certainly the ECG-Q waves, echocardiography, viability scans, MR. I don't know how comfortable your radiologists are at using MR in people with devices. Ours are still not very comfortable. We're trying to help out with that, but it's still an uphill battle. And then in other situations with different distributions of scar and so on. This is from one of my friends. This is a patient with subendocardial and epicardial scar as well, and a patient with extensive anterior and inferior injury, and a lot on the septum as well. And this is what Dr. Steiner was telling us about earlier. This is now my youngest child was not born when I wrote this, and he's now in college, so this is a long time ago, 1988. But it's still valid, and we didn't know a lot back then, but we had recognized certain patterns are very common to be coming from certain locations. I'll leave this to your reading in the printout afterwards, but we have reduced this to something of an algorithm that works reasonably well. It's an exit site. It's not where to put the catheter for ablation, but it's to regionalize where you should start looking. If you have a tachycardia that's left bundle, left superior axis, and this kind of R-wave progression, don't be looking way back here for it. It's not going to be there. It's going to be out here towards the apex. Then we determine VT mechanism. This is very straightforward stuff, and I won't spend much more time on that. Then delineating scar areas. During the procedure, voltage mapping is useful. Electrically inexcitable areas are useful. Sites with a long stimulus to QRS and certainly fractionated later split electrograms, but these two top ones are very devious because our mapping systems are good at identifying low voltage and good at saying we can't stimulate there, but that doesn't mean that that's scar. These are very dependent on wall contact, and we have to be very careful about that. These others are not, though. You won't get a long stimulus to QRS interval with pacing out in the cavity somewhere. And the genesis of these types of electrograms are probably something like this, with a split recording, a split wavefront, versus recording from almost the same site, but with a different orientation of the electrode, seeing this very prolonged electrogram falling into diastole. Voltage mapping has been used to a great extent with very good success by several groups. This is using the biosense system here and coning down the scale to highlight where scar areas and potential border areas are. Although this is very subject to operator contact and experience as well. Here is somebody with a big inferior scar, inferior lateral, and you see these areas here as well. Well, why does he have scar there? Well, it isn't scar, it's poor contact. And when you edit those out, it doesn't look quite so much like a dinosaur anymore. Maybe a dinosaur looks more like a Now, just the raw voltage mapping is not very useful. This is a raw voltage map of somebody with obviously a big septal and anterior and apical infarction. This is very dense scar down here. And this is the scale is 0.05 millivolts to 13.7 millivolts way back here at the base. This is not very useful information here. We have to filter this somewhat. So if you cone it down to a bandwidth, if you will, of 0.5 to 1.5 millivolts, pretty commonly used. Boy, that's still a lot of area to have to deal with. I don't want to deal with all that. So let's cone it down even more to get down to border areas and channels if we can. And slicing it even thinner, some of the Spanish investigators have looked at this. And you end up with something that looks like this, where there's really a potential channel running through here that if you didn't have good mapping information from that area, you may still want to close that off if possible. And a couple of other areas up here as well to try to eliminate conduction through there. So, and then conducting through this from dense scar to more normal myocardium. That's one strategy there. All right, now we're going to see if we can induce and map and ablate. I still think this is your best method for going out to the patient and the family afterwards and saying, we've done something useful here. You have an endpoint to measure, and in order to do that, we look for areas that are likely to be responsible for VT. In sinus rhythm, these are very common. The late split, fragmented potentials, low voltage zones with good contact, pace mapping, and areas with long stimulus to QRS or matches with known VT morphologies. And I tried to induce VT with a catheter at one of these spots, lying in wait for it there, and see if we can see the resulting electrogram. Then in training and watching for potentials, how they behave with entrainment, whether they're bystander sites or good sites, delivering RF during VT. And I really can't remember the last case of scar-based VT that we didn't need some hemodynamic support. I haven't done any cases with percutaneous VADs. We've done, I don't know, 7 or 8 mechanical VADs. They're an interesting lot to have to deal with. Finding a pulse in people with continuous flow VADs is interesting. Now, in going through this process of entrainment, we need to do this right. And so an algorithm to go through here is seeing is there capture. First of all, obviously you can't do any interpretation of post-pacing intervals if there's no capture, but everybody tries from time to time. If there's not entrainment, then go get entrainment. If there is entrainment, you have a match with the QRS. If not, there's still useful information there, because if your post-pacing interval is very far off from your tachycardia cycling frequency, it's just very far off from the electrogram to QRS, you're remote from the circuit. But if these are very similar, then you're close to the circuit and probably in it but in an outer loop. So you're not too far physically from it. If you do have a match that is entrainment with concealed fusion, measure these same variables here. If they're far off, the very important adjacent bystander, where in the United States, if you deliver energy there, you can still bill for it. That's fine. It won't work, but you can bill for it. That's important. If these intervals are closed, then you're in the isthmus with concealed fusion, and then you look at whether you're in the first third, the second third, or the third third, as to whether it is the entrance to the central portion of the common isthmus or the exit site. But it's important to know what you're capturing before measuring that post-pacing interval, whether it's a far field recording or not. Here's just an example from not too terribly long ago. We had been mapping around and found a site that we thought was pretty interesting during sinus rhythm with this delayed potential. This fellow is a biventricular pacemaker. So at 3:11 p.m., so relatively early start of the day for many of you I know, from what I've heard, and he goes into VT. It wasn't hard. Didn't have to work at that very hard, and we find this diastolic potential running along here that's consistently present. We entrained at that site a minute later, and we find that everything's kind of adding up here. The tachycardia cycling is 450, pacing at 470, pacing at 450. Stimulus to QRS is 58 milliseconds. Electrogram to QRS at that site is also 58, and the post-pacing interval matches tachycardia cycling. And then I like to have fun with these every once in a while. Here's an extra stimulus that terminates without propagation. That's always a fun thing to see. It took us a while to go through scanning diastole until we hit that. So that's 4 minutes, 5 minutes into this. And once we got to that site, we reinitiate again and turn on RF right there, and not a second elapses before VT terminates. You know, back in the early 90s, people wanted to build 100-watt generators, so you got to really deliver a lot of energy and really kill a lot of muscle, because these are in scar tissue. These are very deep. You need a lot of energy to ablate these things. Oh yeah, you really do. And this is far more common than not. If you're in the right spot, these are very, very small branches of surviving bundles that go down relatively easily. Now, let's look at some stuff here. Here is the site where we have mapped. That's our diastolic. So what are you going to do with it? You can ablate there, and let's assume that it's entering back through this way. Fine, that's okay. So let's transect that. Great, we've got some ablation lesions. Now, what if your circuit was actually propagating like this? Well, and you've got some ablation lesions that come close, but they don't ever hit it. You haven't done anything. You may have transiently ablated or numbed the circuit such that it can't operate very well, but it's still there. So our techniques are not necessarily working. We can still reinitiate VT. It could be that your contact isn't good, so get better contact. Sometimes if your VT terminates with RF, okay, you're at the right site, but you can reinitiate it. Maybe we need to pace at the VT cycle length and training during tachycardia such that when tachycardia terminates, there's no sudden change in cardiac motion. Occasionally more power is necessary, but not typically so. Sometimes you didn't do all the right stuff. Sometimes you need to go back and revisit entrainment, make sure it was all right. Here's a lady that we had repeated terminations of tachycardia and repeatedly being able to reinitiate it. So here we are pacing the right ventricle consistently during tachycardia, just at the tachycardia cycling, and turn on RF energy here. You see a sudden change in QRS to all paced, but the heart motion hasn't changed, and this one ended up killing the VT for good. Well, sometimes all your techniques are not working so great. You can't find very good sites on the endocardium, so you have to consider alternate sites. There are some ECG indicators, certainly in absence of structural heart disease, but I haven't found anything that's very reliable in the presence of structural heart disease that says it's epicardial or not. Sometimes you just don't have any of these things that look very good. Minimal pre-systolic activation, large area of earliest endocardial activation, and these are some predictors of why it might be a broadband isthmus or deep in the muscle or epicardial. Again, this will be on your presentation. We'll spend more time here. Now, let's ablate some scar areas and see what we can come up with. You can, various strategies here. You can connect known scars, transect known channels, ablate suspected exit sites. All of these have some data for them with careful investigators that are not so easily reproducible by other investigators. Some have given radial spokes along the border. We'll see an example of that. Encircling the border zone, eliminating late potentials with endpoints of what? Making lines. Okay, we completed our lesion set. That's not very satisfactory. Loss of late potentials is a measurable endpoint. Inability to capture with good contact is a measurable endpoint. Hopefully imaging in the future will tell us that yes, we've done some damage there and we don't need to go any further. All right, here's our spot again, where we visited before. We thought it was going this way, and we ablated across that way, but it missed. So let's instead know where the propagation is and transect it. That's knowing how the circuit is actually moving. Or maybe we don't do any mapping, and we just know where there are scar areas, and you can connect those dots there. That's a useful technique, as long as you've done a reasonable amount of characterization of scar. And here's such a situation as that this fella had a large area of scar. He did not do very well during VT, so we've got a lot of lines here that are trying to transect known areas of slope induction. Here's a radial array. I don't know how much sense this makes, assuming that it's coming along this way somehow. These are not so easy to do anyway, as it turns out, and I don't want to ablate too far into normal muscle with this, because these patients, after all, don't have a lot of normal muscle left. Encirclement is even harder to do. I've tried this a couple of times, especially with a big aneurysm and a big thrombus, trying to go all the way around. These are very large ventricles, very, very time-consuming and tedious. Doesn't work too well. And then this is the IDF, you know, comes along and now I used to think this was funny, but Natale, you know, this is what his stuff looks like nowadays. And finally, there's one dot that got in there. Ablating late potentials, that's pretty straightforward. You don't usually get quite this nice result, much like pulmonary vein isolation. Any one point won't do it, but sometimes you'll see these guys delay out and fall off like in PV isolation. All right, what equipment do we need? Irrigated catheter, 8mm tip, 50 watts, go for it. Densely arranged applications may increase the risk of char if you don't have adequate irrigation, especially with 8mm. These are okay to use in scar tissue. It's fine. You're not going to do unwarranted damage as long as you stay in scar tissue. You don't need that much energy typically, but as we see very early termination of RF with RF and VT, you just don't need that much damage in most cases. And these are corroborative evidence of that. The substrate, unfortunately, is dynamic in many cases, and even those of us who are die-hard electrogram chasers and physiologists realize these patients may have substrate changes such that we've taken care of everything we knew about on that day in the lab, but their substrate may change over time. Maybe the modifiers of substrates such as antiarrhythmic drugs are discontinued. They're suppressing something. Now we have to deal with that. So it's reasonable to try to take care of future prospects that the patient has. So targeting not only areas that you know about, but those with potential in the future for causing problems. And that is conduction, blocking off conduction channels and isthmuses that may not be operative on that day. And ablating sites with long stimulus intervals. Nobody has defined how long is. It's 50 milliseconds, 80 milliseconds, 100 milliseconds, and at what current strength. And then what's the endpoint of that? Complete excitability, doubling of the pacing threshold. These are all questions that need to be answered. And just yet. Now finally, we're going to try to assess our results. For my money, I have to talk to the patient and the family afterwards and try to give them some kind of an estimate of how successful the procedure's been. So non-inducibility of VT, we can get in of the target VT easily 85%. All mappable VTs, I'm not sure this is a useful metric. What may be mappable for some is not mappable for others, and vice versa. Any form of VT or VF, especially in people on a lot of antiarrhythmic drugs, that's a hard one to achieve. Inability to capture targeted areas, unipolar oscillation, not very useful in scar-based VTs, very useful in patients with normal hearts. And if we had a slow tolerated VT as the target, we have to eliminate that. Multiple mappable VTs, we only have an ICD electrogram in most cases. We don't know what morphology we're dealing with, and the cycle links may be very similar. So we need to address as much as possible within the bounds of safety. Now, what about safety? Death, especially from heart failure, not very common, but it is. I've lost a couple of people in my years with this, not very expectedly. Stroke is uncommon, perhaps because of our imaging prior to procedure and avoiding the endocardium in patients with non-thrombus. Perforation, quite uncommon in these cases. It'll be the right ventricle that perforates, if anything, not the left, with your just regular quadripolar catheter. Worsening heart failure, especially with a lot of arrogant delivered valve damage, aortic valve damage. Many people are going to transeptal nowadays and avoiding that entirely. Myocardial infarction, quite rare. Our biggest problem is vascular problems, which many patients have, and so forth. Now, when should we do this? This is a running battle here. For an electrophysiologist, you know, we're available. Call us up. I'm preaching to the choir, as we say in the United States. You people are very good at this and scratching your heads and wondering why you don't get more referrals. Well, a lot of people still, referring doctors still have the perception that it's a dangerous procedure, that's not very successful. But all the benefits of the patients, avoiding shocks, avoiding antiarrhythmic drug toxicity, and even prophylactic ablation with Smash VT and the VTEC study with Karl-Heinz Cook. Very similar results. The scales are a little bit different, the time scales are different, but survival and event-free survival is better with prophylactic ablation. So in the future, I think we can anticipate increasing numbers of VT patients. We're going to have to deal with more and more of this. More image integration to help us plan our procedures more intelligently, and better imaging techniques to tell us when a lesion has been made. If it wasn't successful, don't need to keep hammering at that spot because there's already a lesion there. Patients are probably better served with earlier ablation. That avoids all these other things here. And so in summary, it's a challenging procedure. Preparation is important, execution is important, and patient safety is obviously of paramount importance. And I try to teach my trainees, try to keep a cool head during this procedure. You don't want to be flying around backwards.